I wonder how we would like to treat such a patient. We'll take a good look and think about it, and we'll come back to that at the end of the, before the end of the lecture. Now we're going to talk about distal femoral fractures. In this lecture, we're going to learn about the main types of injury, the treatment aims, the reduction techniques, surgical approaches for reduction of intraarticular and metaphyseal components of the fracture, the various implants available for fixation, and the evolution in surgical treatment of distal femoral fractures. We are all aware of the AO classification, and it is as simple as that. Type A is extraarticular, type B is partial articular, and type C is complete articular. If we move on in the same class, we get higher grades of complexity, so that in A1 it is simple metaphyseal, in A2 there is a wedge fracture, and in A3 it is multifragmentary metaphyseal. Type B is a partial articular, and it goes like B1 is a lateral condyle, B2 is the medial condyle, and B3 is a coronal Hoffa type fracture. Type C is simple articular, simple metaphyseal. Type C, that was C1. C2 is simple articular, multifragmentary metaphyseal, and type C3 is multifragmentary articular and multifragmentary metaphyseal. We have two groups of patients who suffer such fractures. We have young adult patients who get high energy trauma. It is often an open fracture. It is often an intraarticular fracture, and it is often combined with a polytrauma. There are other elements of the injury. Then there are the elderly low energy group who have osteoporotic bone and who may have a periprosthetic fracture. This is an example of the low energy fractures. And this is an example of the high energy fractures. Our aims in the treatment of such injury is, number one, respect the soft tissues. Number two, reduce the intraarticular component. Number three, align the metaphysis to the diaphysis. Number four, provide adequate fixation to allow early mobility. Number five, to treat each component separately. In such injuries, when we have an articular and an extraarticular component, and it is possible to use more than one treatment principle in the same bone. If we have more than one component, an intraarticular and extraarticular component, we should know that the articular component requires an anatomical reduction of the articular surface. This anatomical reduction requires direct reduction techniques, which means an open reduction. And this articular component requires absolute stability, which means interfragmentary compression. And all the time while we are treating the intraarticular component, we should keep in mind that we still have to fix the metaphysis to the diaphysis. So the metaphysis to the diaphysis fixation, our aim is to restore alignment, length, and rotation. This we can do by using the indirect reduction techniques, that is closed reduction. We don't need to open the fracture site. And this component of the fracture can be and should be treated by relative stability using an intramedullary nail or a bridge plate. So the intraarticular component of the fracture, how do we approach it? We approach it by an open approach, but the open approach should be only for this articular component. We use an anterolateral approach. Why do we use an anterolateral approach? Because we need an anterior approach to visualize the articular surface, and we need a lateral approach because we put our plate laterally. So we make a compromise and we use an anterolateral approach, which gives us enough exposure to visualize the articular surface. This is the skin incision. This is after we expose the articular surface, we can see the components of the articular fracture. We do anatomic reduction by this open method, and we put provisional fixation by a clamp or a K-wire. Then we do definitive fixation of the articular components by interfragmentary screws, as we outlined before, keeping in mind all the time that we are going to put a plate this way to fix the articular block to the diaphysis. When we put the screws that we are using to fix the articular component, we should keep in mind that we are going to fix this articular block to the diaphysis. So we have to keep the space clear where we are going to put the fixation method, whether it is a nail or a plate that we will use to fix the articular block to the diaphysis. So we usually put the articular interfragmentary screws this way, keeping this part clear for a plate fixation, and we don't put screws posteriorly because of the notch. We have to keep in mind that the lateral condyle is prominent anteriorly than the medial condyle, and then we have to place our screws in such a way that we do not have articular penetration, or we don't have penetration of the notch posteriorly. Our aim when we treat the articular component is to downgrade the fracture. Downgrade means that we want to convert this type C fracture into a type A fracture. How is that possible? When we treat a type C1 by fixing the articular elements, we convert this type C1 into a type A1 fracture. That is, there is no articular injury now that we fixed it, and we only have a simple metaphyseal component. C2 can be converted into an A2 type fracture by fixing the articular component, and C3 into A3. Then we need to fix the metaphysis to the diaphysis, and to do that we need to restore the alignment, the rotation, and the length. We use indirect reduction methods, such as a towel or a pillow under the knee to relax the gastrocnemius and restore the bow of the femur. Also, we use distractors or external fixators to do traction and to do indirect reduction. Also, we can use, through the open approach we have just performed, we can use joystick pins or Shan's screws in order to manipulate the fragment into a proper reduction. But we do not open on the metaphyseal component. What implant do we use? We use any implant that can achieve alignment, length, and rotation, and relative stability. In this way, we may use an intramedullary nail or a bridge plate. The bridge plate we use through a MIPO technique. We have just opened this part for exposure and management of the articular fracture. We slide the plate in a submuscular extraperiosteal way, and we do limited incisions over the relevant screws that we are going to use to fix the plate to the shaft. This is the LISS plate. It was designed to use as a MIPO device to fix the distal femoral fractures, and has a special jig to allow introduction of the screws into the locked holes. However, this was not very popular even in Egypt or even outside Egypt. But this is an example of how we use, how we do MIPO fixation of the distal femoral fractures. We use screws here to restore the articular surface outside the plate, and then we put a MIPO plate and we put screws in the distal component and the shaft like this. Now back to the X-ray that we started with. Now we would like to think again, what would you use to fix such a fracture? We began by defining the fracture. What type of fracture is this? I didn't understand that. According to the AO classification, this is an articular fracture that is definitely type C. So is it C1, C2, or C3? There is, as you see here, there is metaphyseal comminution. So it is one of the multifragmentary metaphyseal. But what about the articular surface? This is what I'm concerned about. This is not a simple articular fracture. Actually, you can see here a coronal element. However, this fracture, when I treated it, I thought that this articular element could be properly fixed by screws, and this is what I did. I did fixation of the articular fractures by screws, and then I did an intramedullary nail. Some would say that a plate would have been a better option, but anyway, this can be done if you think you can restore the articular surface and get stable fixation. The coronal plane fracture, the Hoffa fracture, is one of the fractures that has to be reduced open because it is an articular injury. You have to make an anatomic reduction. You put screws, interfragmentary screws. You have to be careful not to penetrate the articular surface posteriorly, and you have to put your screws away from the articular surface, or you countersink them beneath the articular surface anteriorly. However, the coronal fracture can still have a metaphyseal component like here, and in this case you do your articular fixation, as we said, and then you do the metaphyseal component. We had the 95-degree blade plate that was in the 90s and early 2000s. Then we have the DCS. Then we have now the LCP, the locked compression plate. What's new is that you may have a variable angle device to allow you to place your locked screws in different directions. This is very important because if you have a screw with a fixed direction near the articular surface, you may penetrate the articular surface, or you may have to avoid using an articular, a locked screw near the articular surface just to avoid penetrating the articular surface. So the development of a plate with a variable angle device is a valuable addition to our treatment strategies. What about periprosthetic fractures? They have the same principles and techniques as other distal femoral fractures, but the primary question to answer is whether the arthroplasty is stable or not. If the arthroplasty is not stable, then you should consider revising with a distal femoral replacement. But if it is stable, you may try to preserve the prosthesis and you fix the fracture. And to do that, you have to use a fixation method that does not interfere with the prosthesis or its fixation, such as this. So the take-home message is that you have two main patient groups, low energy, high energy. You have two main fracture components, intraarticular and the metaphyseal-diaphyseal component. The intraarticular component requires direct reduction and absolute stability. The metaphyseal-diaphyseal component requires indirect reduction and relative stability. Thank you very much. I hope I've not been too long.
Thank you so much, our beloved professor, Professor Abdelsalam Eid, for this very interesting talk about distal femoral fractures. Dr. Ahmed Sheikh, you are the moderator with our great professor.
معك فندم. First question, it's a very good question. It's a question of myself also. What about double plating in cases of comminuted distal femoral fractures? Using a medial and lateral plate to get a better stability.
Let me tell you something. In distal femoral fractures, you are very concerned about varus angulation and loss of fixation. So you have to be secure about the medial component of your injury. If you have doubt, you may even put a bone graft medially in order to provide the early union so that your fixation will not fail. So if you are, you feel insecure about your fixation, I think you may, why not use another plate? And there is also, I have not read about it, but I've thought about it a lot. You use a nail and a plate. It's like an augmentation plate over a nail, but in the primary situation, you put a nail, and this nail will prevent varus collapse, and it will have very good axial stability, and then you put a plate. I have thought about it, but I've never done it in a primary setting. Perhaps it's worth studying.
Yeah. A question
but I think, Professor Abdelsalam, if you put a nail with a plate, you have to do the plate in a biological manner because you will interfere with intramedullary and extramedullary vascularity.
Certainly, sure, I agree. And if you put a nail, you usually have a certain amount of stability. You put your plate to augment this stability, and you don't depend solely on the plate. So you need only a couple of screws above and below, and you can do it in a MIPO way, certainly.
Yes, sir. Thank you.
One question from the previous lecture, really, it's about using a retrograde nail in young adults, and what is the risk of condylar knee injury or arthritis resulting from going into the knee joint?
I think it's a question for you, sir.
I didn't have a look on the retrograde nail, but when you are careful, you do the entry properly from one go, you are not jeopardizing anything in the knee, and I don't think there is an increased risk of having osteoarthritis because the notch is already it's not a weight bearing area, and the contact forces in this part is not that much.
I agree with you. Supra nails have been in use for many years now, and I don't think a properly done supra nail has serious adverse effects, and sometimes you are forced to do it. Perhaps the question comes from some concept I have heard before, that it is equally possible in shaft fractures to use an antigrade or a retrograde nail, whichever you feel easier or more familiar with. So personally, I would not use a supra nail unless I have to. I mean, I would not violate the knee joint unless I have to, if it is a distal fracture or so. But if you can use an antigrade nail, I think it's more logical.
A question about how would you fix ipsilateral fracture femur and C3 distal femoral fracture?
I think we have demonstrated that in the lecture.
Yeah.
You have to start with the articular component. You fix it. You reduce anatomically, fix interfragmentary, and then you use a MIPO technique to put a plate or even a nail, if you wish. If you can do that, you can put a plate or a nail to fix the metaphyseal component.
Yeah. Another scenario about the isolated medial femoral condyle fracture with metaphyseal extension. Would you still go for with intact lateral femoral condyle and lateral cortex? Would you fix this with the standard distal femoral lateral plate, or would you go to fix it from the medial صحيح.
I think it would be more logical to go to the injured side. I mean, you need to buttress this fractured condyle so that it would not displace. If you put just a plate on the lateral side and screws, your dependency is just on the screws as interfragmentary fixation devices. But if you put a plate, you get the benefit from buttressing of the plate against the condyle.
I think this will be a last question, and it's a technical tips. Our colleague, would you like to know some details about how would you, what's the sequence of putting the parts together with the articular fragments and then the metaphyseal? What is the, how would you just put this in order when you get intra-articular fracture community and you are going to ORIF this fracture?
If you allow me to share the screen again, I can.
Absolutely.
It takes a little bit of time. Sorry. One moment, please. Yes.
No,
take your time, sir.
Can you see the picture now?
Yeah.
Yes, sir.
So you open and you view the articular fracture, and you have to have a good view. In orthopedics, it's all about viewing. You don't compromise that you don't see enough. So you see all the elements of the articular injury, and using open reduction and direct reduction methods, you can reduce the articular components together. And then when you reduce them anatomically, you can put a clamp or a K-wire or both. I usually put the clamp, then I put a K-wire, and then you may put the interfragmentary screws. And when you put the interfragmentary screws, you put them here, 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 so that you allow this area for the placement and passage of the plate like the arrow. So now we have anatomic reduction, we have placed our provisional fixation, we take x-rays and it's okay, so we put the screws and then we take the plate and slide it under the muscle. This is the way we put our screws, and this is the space we keep open for the plate. And this is the way we put our screws to avoid the patellofemoral joint and the notch. And then we do the reduction of the metaphyseal component using extraction, traction, and joysticks. And we slide the plate like this. And this is what we end with. I hope this answers the question.
Yes.
Absolutely. Thanks so much, dear Professor. Thank you.
Thank you very much.
Thank you so much, Professor Abdelsalam, for joining.